Hi, Miss Nikki here. Welcome to part 2 of the respiratory system. We're going to get into a little bit more detail and talk about more physiology, where in the first part we just kind of covered the anatomy. Hopefully we can look at the movement of oxygen and carbon dioxide here, and we have an overall understanding of this process from when we covered cardiovascular. So we know that we're going to take deoxygenated blood out to the pulmonary capillaries. We're going to drop off CO2 so we can exhale it, and we're going to pick up oxygen. That's going to travel in our blood vessels. Remember, it goes back pulmonary veins, and then it goes to the aorta once it passes through the heart. And then we're in our thoracic aorta, abdominal aorta, dropping off oxygenated blood to all of our organs and tissues. And we see the exchange of gas at the tissue site. So then when we say systemic, hopefully we're thinking body and pulmonary. By now, we know lungs. So here's in words, kind of the definition of each. What is respiration? This involves all 4 of these processes. So we're exchanging gases between the atmosphere and your body's cells. First thing we have to do is pulmonary ventilation. We have to move the air in from the atmosphere into the lungs, and specifically the alveoli, because we know that that's where gas exchange takes place. So now, step 2, we actually have to do the gas exchange. So we're going to drop off the CO2 from the blood. We're going to pick up the oxygen at the alveoli, right? Then we're going to move into gas transportation. We're going to move the oxygen in the blood from the lungs out to the body cells. And then 4, we're going to do tissue gas exchange. So remember when we did our flow of blood through the body, and we talked about pulmonary capillaries. Before that, we had pulmonary arterioles, capillaries, then we said venules, then we said veins, and then we took that all the way out to, we did either biceps brachii or we did gastrocnemius, right? We said when we get to the bicep brachii, we have to drop off, if you remember, we did arterial, and then we did capillary. And remember, I made it a point. I wanted you to say dropping off oxygen, picking up CO2. So we've really talked about these gas exchange stages already when we did cardiovascular. Again, putting it into words, right? So the air has oxygen in it. We're going to inhale that into our lungs. The alveoli are going to do the gas exchange at the pulmonary capillaries. We're going to take the blood from the lungs and transport that oxygen. The oxygen is going to diffuse into the systemic capillaries. CO2 is going to diffuse out. As the oxygen diffuses in, we're going to transport that CO2 back to the lungs. When at the pulmonary capillaries, we're going to diffuse that CO2, and then we can finally exhale the CO2 from the alveoli into the atmosphere. So hopefully by now, when we look at this image and these numbers that are here, that makes sense with what we just talked about. So they kind of are just breaking it down step by step, but you should be able to look at this image and explain what's going on. So pulmonary ventilation, which is breathing, you can see the definition there, air movement between the atmosphere and alveoli. So we're just kind of going into each one of these just a little bit more, right? So we have inspiration, which brings air into the lungs, and we have expiration, which forces air out of the lungs. And something that they don't usually differentiate between is quiet breathing and forced breathing. So think of quiet breathing as you're at rest. It's just this rhythmic, you probably don't even know you're doing it, right? Forced breathing is when you go to the doctor's office and they put the stethoscope on your back and they say, okay, take a deep breath for me, right? And you do that. That's that forced breathing. This is also the breathing that we're doing when we're exercising. So if you want to think of quiet breathing, at rest, forced breathing, exercise, that's fine. They also want you to realize that part of your autonomic nervous system, part of your brainstem is going to regulate breathing, and we'll talk about those in just a second. Skeletal muscles have to contract. They have to change the thoracic volume in order for air to flow in. So we're going to talk a little bit more about that. They're basically saying volume changes are going to result in pressure changes, and air is going to move down its pressure gradient. So we're going to see diffusion, and we're going to talk about moving air from high to low concentrations. If you wanted to see the muscles of breathing, skeletal muscles of breathing, you can see for quiet breathing, we're talking about the diaphragm and the external intercostals. And there's an image coming up in just a second. The diaphragm is going to flatten when it contracts, and the external intercostals are going to elevate. So the diaphragm is going to pull down, and the intercostals are going to flare out. The forced muscles of inspiration, you can see all of these: sternocleidomastoid, scalenes, pectoralis minor, serratus posterior, superior, internal intercostals, abdominal muscles. So we'll look through those in the next image. You do not have to memorize all of those. I just want you to see that a forced inspiration requires a lot more muscle contraction. And then you should be thinking, if it's a lot more muscle contraction, a lot more ATP is being used. So here we have the diaphragm. So the diaphragm pulls down and the intercostals flare out, and they're kind of under there. And then these are all of the muscles that are used during forced breathing. Some of these we learned in 201 during skeletal muscle, and some we did not, right? So pectoralis minor we did, sternocleidomastoid we did, but you can see some of the other muscles that are required for taking in that forced inspiration, and then some of the muscles that we use for forced expiration, and that would be more abdominal muscles. So volume changes in the thoracic cavity. They want you to realize that the thoracic cavity is expanding. It is changing not only vertically, but laterally and front to back, anterior and posteriorly. So I'll show you on the next image. I think it's a little bit better. Vertical changes result from the diaphragm moving down. So when you inhale, they move down, or the diaphragm moves down, and when you exhale, the diaphragm moves up. So they're showing you kind of this box for the thoracic cavity. So we're showing you how the volume changes. When you're doing inspiration, the diaphragm moves down. The lateral changes, you can see that the ribs are elevated and that it's widening laterally. That's due to those external intercostals. And we also see moving from front to back. So the anterior posterior changes. So you're going to see that the sternum moves out during inspiration and it moves back during expiration. So the entire volume of your cavity is shifting. Then they talk about Boyle's law. They're trying to show you how changing the volume changes the pressure. And we said air moves down its pressure gradient from high to low. So they talk about Boyle's law. They say at a constant temperature, the pressure of a gas decreases if the volume increases. So as the volume increases, the pressure decreases. If you decrease the volume, the pressure increases. So these red little spheres, they're trying to show you gas molecules in a container. If you raise the plunger here, if you're raising the plunger up, you're giving those gas molecules more room to move around. You've increased the volume, and therefore those molecules are not bouncing around and hitting all over each other as much, and so you have decreased pressure. If I push the plunger back down, if I squeeze all of those air molecules into a confined space, it increases the pressure inside that cavity. And this is exactly what's happening in our thoracic cavity. So we have to talk about pressure gradients, and then I'll talk about exactly what's happening in the lungs. So air pressure gradients exist. If the two places are interconnected, the air is going to flow from high to low pressure until the pressure is equalized. In this first example, they're equal. So the area is equal, the space is equal, the number of molecules is equal. So there's no airflow. In this example, this was B. What did we do to B? We increased the volume, right? This was the volume for B. Now this is the volume for B. So we increased the volume, so what happened to the pressure? We decreased the pressure. So now this area is high pressure compared to this area, which is low pressure. And so the air moves from high to low. This would be inhale. Now we had this large volume. What did we do? We decreased the volume. When we decreased the volume, what happened to the pressure? The pressure increased. So now we have high pressure here, we have low pressure here. Where's all the air moving? It's moving from B into A, and this is what happens when we exhale. So in the lungs, what's happening? I'm going to draw that box again, right? So this is the volume in the thoracic cavity. Extra little squiggle. All right, remember our diaphragm's here. So what happens to the diaphragm when we inhale? We said the diaphragm flattens, right? It moves down. So the diaphragm moves down. What happened to that volume? Did we increase the volume in the thoracic cavity by moving the diaphragm down? Yes. And if we increased the volume, we decreased the pressure. So now out here in the atmosphere, the air that we're breathing in, the pressure is higher. So what happens to the air? It moves into the lungs. Why does it move into the lungs? Because the pressure is lower in the lungs. So this is how oxygen moves into the lungs. So then what happens when you exhale? Do we take this large cavity, we snap our diaphragm back up, and now our volume is going to decrease, right? So we have decreased volume in our thoracic cavity. So that causes increased pressure. So what happens to the air? It moves out. For us, we're going to kind of stick with the normal. So at sea level, atmospheric pressure is at about 760. This is really kind of unchanged in the breathing process. You can change atmospheric pressure with altitude, but we're going to kind of just stick to this normal value at sea level of where we would be. But the air is thinner or under lower pressure, and that will affect gas exchange if you go to a really high elevation. Alveolar volume, this is the collection of alveoli. We've seen this term last PowerPoint, intrapulmonary pressure, pressure in the alveoli. This fluctuates with breathing. It may be higher or lower or equal to atmospheric pressure. It's equal to atmospheric pressure at the end of both inspiration and expiration. We also have the intrapleural pressure. So this is the pressure in the pleural cavity. It does fluctuate with breathing. It is lower than the intrapulmonary pressure. Remember, that's what keeps the lungs inflated, having that 4 millimeters of mercury difference, pressure differences between the intrapulmonary and the intrapleural pressure. Go back and look at chapter 1 if you don't remember. We said in the lungs the pressure is atmospheric pressure, it's that 760, and then we have 756 in between the pleura in the pleural cavity, and that pressure is what keeps the lungs inflated. So volume changes create pressure changes. We just saw that, right? You have this volume in the thoracic cavity, and you change that volume, it changes the pressure, and that causes air to flow in or out depending on what we're talking about, right? So during inspiration, the thoracic volume increases, therefore the pressure, so you can say volume increases, pressure decreases, so air flows in from the atmosphere. During expiration, the volume decreases. So what happens to the pressure? It increases, so air flows out. We should be able to follow along now with the mechanics of breathing, and specifically this is breathing at rest. You can see this one we're doing inspiration. So the external intercostals contract, the diaphragm contracts, the thoracic cavity volume increases. The pleural cavity volume expands, and we see the alveolar volume expand. This causes the pressure, intrapleural and intrapulmonary pressure, to decrease. So the space between the pleura and inside the lungs, all of that pressure is going to decrease, and that allows air to flow down the pressure gradient into the lungs. So air flows in from high to lower pressure. During expiration, what's going to happen? Diaphragm and the external intercostals are going to relax, and we're going to see the thoracic cavity volume decrease. We're going to see a decrease in the pleural cavity. We're going to see a decrease in the alveolar volume. The intrapleural pressure is going to increase, the intrapulmonary pressure is going to increase, and we're going to see air flow down the pressure gradient out of the lungs. Do you want to come back and mention the autonomic nuclei within the brain? So this is in the brain stem. Medulla oblongata and the pons both have respiratory centers. We also have brainstem neurons that are going to influence those respiratory muscles. So remember, if you have the diaphragm moving, remember we have to have a neuromuscular junction. This has to be controlled by some sort of nerve to tell that diaphragm to contract, right? So we're going to see lower motor neurons that are going to project into the respiratory muscles, and specifically the axons that innervate the diaphragm travel in the phrenic nerve, and then in the intercostals we have intercostal nerves. Next, we have to talk about chemoreceptors. So most of us know these are going to monitor changes in some sort of chemical concentration. We're specifically talking about hydrogen ions, carbon dioxide, and oxygen. Specifically, these central receptors are going to monitor hydrogen ion concentrations. And this really changes with the concentration of carbon dioxide. So remember, we have carbon dioxide plus water. That's going to break down to carbonic acid, and then that's going to further break down into hydrogen ions and bicarbonate ions. So these central chemoreceptors detect hydrogen, and that has a direct relationship to the amount of carbon dioxide. The peripheral chemoreceptors, these are in the aortic arch, carotid artery, and these detect hydrogen ion differences, but this is different or not necessarily related to carbon dioxide. So these peripheral chemoreceptors can detect hydrogen ion concentrations that could deviate from normal, also due to maybe kidney dysfunction, right? So we'll talk a little bit more about urinary, and we'll see how all of this links together. We also have irritant receptors. These are in the air passageways, any sort of particulate matter. We have baroreceptors, remember, that have something to do with measuring stretch or pressure. We talked about baroreceptors in blood pressure. And then we have proprioceptors. These are in the muscles and the joints, and they're going to be stimulated by body movements. Remember, your proprioceptors kind of know where you are in space and time, right? So they know the contracted state of your muscles. They know functions of your joints, kind of how they're moving. We gave the example in 201, if you had your eyes closed, would you still know your legs were crossed? And you would, because even though you can't see it, you're sending messages to your brain. Kind of the big picture point that they want you to see here is that we do have chemoreceptors. They are detecting all of these hydrogen ion concentrations, these partial carbon dioxide values, and indirectly partial oxygen values that we'll talk about in just a second. We do have something called apnea, which is the absence of breathing. It can occur voluntarily. You can also do this if you're holding your breath. It can be drug-induced, and we know sleep apnea, this seems to be pretty common. This is a temporary stoppage or cessation of breathing during sleep, and we can put a CPAP machine on you, which is continuous positive airway pressure, to make sure the air is always flowing in. So we do have reflexes, part of the nervous system, that can control our rate and depth of breathing. So we're talking about pons and medulla, right? So ventilation is going to increase if your chemoreceptors detect an increase in hydrogen ion concentrations in the cerebrospinal fluid, or if you have blood carbon dioxide or hydrogen ion concentrations. So remember, if you have high levels of hydrogen ion, that means your blood is acidic, right? If you have too much carbon dioxide, your blood is acidic. What are we going to do? We're going to increase ventilation, hoping to expel more of that CO2. So again, let me write that equation down. You think this is going to come back? You think you have to know it for the test? Yes. So is it possible that hydrogen ions can combine with bicarbonate to form carbonic acid, to form CO2 and water, and you could exhale or increase ventilation to expel more CO2? Yes. If ventilation were to be decreased, it's probably because your chemoreceptors are detecting a decrease in hydrogen ions or carbon dioxide levels. So continuing on this same topic, when we talk about chemoreceptors, they're saying blood carbon dioxide levels are the most important stimulus that affect your breathing. Just raising your CO2 levels in a small increment can double your breathing rate. The CO2 causes the sensitive chemoreceptors to detect that hydrogen ion concentration, and remember the CO2 combines with water to form the carbonic acid, which then can break down into hydrogen ions and bicarbonate ions. But really this carbonic acid is going to trigger these increases in hydrogen ions. The central chemoreceptors are going to detect that, and it's going to cause you to start breathing faster. Oxygen is not a sensitive regulator of breathing. Oxygen has to drop by quite a large amount to have any sort of effect independent of CO2. So when oxygen drops, it's because those peripheral chemoreceptors that can detect carbon dioxide and hydrogen ions are more sensitive to blood carbon dioxide levels. So it's not necessarily the oxygen dropping that's affecting, it's the oxygen dropping which then affects the sensitivity to the amount of carbon dioxide you have in the blood. We've talked about airflow, right? We've talked about air moving in and out of the lungs with each breath. We've talked about pressure gradients. We talked about if you increase the volume of the thoracic cavity, that decreases the pressure. And if you decrease the pressure, you're going to see air move in, right? We did that with inspiration. So we've talked about atmospheric pressure and intrapulmonary pressure. The other factor that we need to think about in terms of airflow, air moving in and out, has to do with resistance. So if pressure gradient increases, airflow into the lungs increases. If resistance increases, airflow goes down. So remember resistance when we talked about blood flow, right? Bumps in the road. So think about the same thing with air moving into your lungs. If you have anything blocking the flow of air moving into your lungs, airflow, the amount of air moving in and out, is going to lessen. So pressure gradient, difference between atmospheric pressure and intrapulmonary pressure. This changes by altering the volume of the thoracic cavity. Resistance factors. So if you change the elasticity of the chest wall, if your bronchioles become constricted, right? If you have any sort of collapse of the alveoli, those would all be resistance factors which are going to make it more difficult to move air in and out of the lungs. When we look at these factors individually, when we break them down, when I look at kind of chest wall elasticity, I'm usually thinking of this last one. Something happened to the elastic tissue. It was replaced with scar tissue. If you remember when we did skin chapter, we talked about regeneration versus fibrosis. So fibrosis is creating scar tissue. It just holds the organ or tissue together. It doesn't allow it to be functional anymore. You could also think about arthritis in the thoracic cage. You could think about malformations that would cause your thoracic cavity to not be able to expand as well, right? For bronchial diameter, so if you have bronchial constriction, some sort of blockage, that's going to increase resistance. You're not going to be able to exchange air as well. So this could be sympathetic activity, this could be histamine, cold, mucus, inflammation, and we usually fix that by giving you some sort of stimulant like epinephrine. That'll do bronchial dilation, that'll decrease the resistance, and if you decrease resistance, you're going to increase airflow. What happens if you increase resistance? You're going to decrease airflow. Kind of the difference here too is when we talk about elasticity in the chest wall, this is usually things that cannot be fixed, right? You're not going to fix the arthritis. You may or may not be able to fix the malformation. Scar tissue, you're not going to be able to fix that. Bronchial constriction or occlusion, we could remove the occlusion. We could give you epinephrine to open the passageways, have bronchial dilation, and then have increased airflow. The last one here, when we talk about collapsed alveoli increasing resistance. So the type 2 cells are not producing enough surfactant. If they're not producing enough surfactant, then you're going to have the walls of the alveoli coming together. That's going to decrease the amount of airflow, right? So this is important for infants, premature infants. We talked about not producing enough surfactant back in reproduction. Compliance is this term, ease with which the lungs and the chest wall can expand. And this is determined by that surface tension, which surfactant helps with that, and the elasticity of the chest. So the more the lungs can expand, the greater the compliance. This image here, they're just trying to show you all of the factors, right? All factors that influence airflow or the exchange of gases. So one is the pressure gradient. So we have to have the correct pressure gradient, and that's affected, right? Pressure gradient is affected by volume changes in the thoracic cavity. So what can affect the thoracic cavity volume changes? Well, you could have issues with compliance, right? You could have elastic issues, right? Elastic fibers, elasticity. You could have blockage of bronchioles. You could have reduced surfactant, and that would cause the alveoli to collapse. So something can physically be wrong with the chest. Something could be wrong with the surface tension at the alveoli. Something could be wrong with the bronchial diameter, either too constricted or too dilated. So basically, we're looking at how much air is moving in and out of the lungs per minute. So if we look at this, you can see it'll get broken down into air per breath, then it'll get broken down into breaths per minute, and we can come up with this minute ventilation. So this is the amount of air moved between the atmosphere and the alveoli in 1 minute. They want to point out that there are some areas, some zones, where we're not going to exchange respiratory gases, and they call this the anatomical dead space. There is also sometimes loss of alveoli. So let's say you had pneumonia and some of your alveoli were damaged and it's replaced with scar tissue. So sometimes they call this the physiological dead space. It encompasses both the dead space that's normal to lungs, along with any loss that you might have. The spirometer is used to measure respiratory volume. So they'll look at tidal volume, inspiratory reserve, expiratory reserve, and residual volume. And I think the images on the next slide make it a little bit better. But tidal volume, the amount of air inhaled or exhaled per breath during quiet breathing. And then you have the inspiratory reserve volume, the amount of air that can be forcibly inhaled. This can look at compliance. And then expiratory reserve volume, the amount that can be forcibly exhaled. This will look at elasticity. And then we have the residual volume. This is the amount of air that's left in the lungs after a forceful expiration. This image can be a little messy, but let's just break down some of these terms here. This tidal volume, this would be the normal air taken in and expelled during quiet breathing. So this is kind of your normal at rest. This is that forceful inhale. And when we look at forceful inhale, we said that has something to do with compliance. And if we look at kind of the level at which, the volume at which you can do this forceful inhale, that compliance would be something like surfactant, something about alveoli themselves. And then we said there's this forcible exhale. And that forcible exhale has something to do with elasticity. And when I think elasticity, I'm thinking about elasticity of lung tissue. And then I'm also thinking about rib cage, right? Remember those changes, either anterior, posterior, lateral, superior, inferior, right, to change the lung volume. And then you can look down here, they have total lung capacity. So if I add all of these up, I can look at the amount of air the lungs can hold. And by looking at individual volume changes in the lung when I forcefully inhale and forcefully exhale, I can tell a little bit about the health of the lungs. Now we're going to move into variables that influence gas exchange. So just to put this picture up again, we know pulmonary circulation is what happens in the lungs at the pulmonary capillaries. Systemic circulation is happening at the tissue level, and we can see those systemic capillaries. So we start here with pulmonary gas exchange. So this is the movement of oxygen. So oxygen is going to diffuse across the respiratory membrane from the alveoli into the capillaries. The movement of carbon dioxide. Carbon dioxide is going to diffuse from the blood to the alveoli. So here they're showing you pulmonary gas exchange. We're here at the alveolus, so we know this is the lung, and we're here at the blood. So we're looking specifically at pulmonary capillaries. And we're seeing our red blood cell, and we're seeing oxygen move in. This would have been from the air in our lungs, right? Oxygen's moving in, and the CO2 is moving to the lungs to be exhaled, right? So this CO2, we're going to exhale, and this is the oxygen that we inhaled. Then they come over here and we look at pressure differences. So we're looking at oxygen, and we're seeing that the pressure of the oxygen is higher in the alveoli than it is in the blood. So we're going to see the oxygen move from the alveoli into the blood. We can see that the pressure of the carbon dioxide here at 45 is higher in the blood than it is in the alveoli, so the CO2 moves into the alveoli. So emphysema, you've somehow damaged this pulmonary gas exchange surface. You can have inflammation of the air passageways. You could have damage of the elastic connective tissue. You can have decreased total number of alveoli. Usually this is caused by smoking. Lots of respiratory diseases can affect, on multiple levels. So they're trying to show you that if you have some sort of respiratory disorder or disease, it can affect the number of alveoli. It can happen because of thickened respiratory membrane. We can see changes in the bronchioles, like with asthma, or you could see pulmonary embolism. Something is blocking the perfusion of blood, right, or the perfusion of air. So disease results in decreased oxygen levels and increased CO2. And CO2 makes your blood acidic, and obviously decreased oxygen is bad for cellular respiration, and it limits the amount of ATP that you can use. And remember, ATP is there to cause all of our muscles to contract and all of our neurons to fire. So big problem. Tissue gas exchange. So now I'm talking about at the systemic tissue level. Oxygen is going to diffuse out of the systemic capillaries and enter the cells. Carbon dioxide is going to diffuse from the cells out into the blood. So here we have tissue gas exchange. We're seeing the systemic capillaries. You're seeing the cells and the blood, and we're saying the blood is dropping off oxygen and it's picking up CO2. Remember, the cells are creating that CO2 from cellular respiration. So remember, we take glucose plus oxygen, and we break that down into water and carbon dioxide and ATP energy. So this carbon dioxide that the cells are creating that gets pushed over into the blood that we eventually exhale, that comes from cellular respiration. Again, they're trying to point out what is actually the driving force from oxygen moving from your blood into your tissue. It all has to do with pressure differences. So moving from high to low pressure is what causes the oxygen to move out. And then from the CO2 at 45, moving out into the blood at 40. And that's what causes the carbon dioxide to move from the tissue into the blood. You can see here with oxygen transport, only about 2% of oxygen is actually dissolved in the plasma. The majority of oxygen is bound to the hemoglobin. You can see oxyhemoglobin and deoxyhemoglobin written in this form. So the HB is the hemoglobin with oxygen bound to it. Without oxygen bound to it, we're going to see this hydrogen ion binds. So without deoxyhemoglobin with oxyhemoglobin. And that's exactly what we're measuring with a pulse oximeter. So pulse ox is attached directly to the finger. It's non-invasive. It's an indirect way to measure oxygen. What are we looking at? We're looking at the ratio of oxygen bound to hemoglobin versus no oxygen bound to hemoglobin. So a normal reading should be above 95. Carbon dioxide has 3 ways that it can be transported. And you'll see that the majority of it is to dissolve in the plasma as bicarbonate ions. So about 7% is dissolved in the plasma compared to 2 with oxygen. And about 23% is actually bound to hemoglobin. So in oxygen, it's 98%. With carbon dioxide, only about 23%. And you'll see it written as this, carbaminohemoglobin. The majority of the carbon dioxide is broken down into bicarbonate and hydrogen ions. So here we have that equation again. We have carbon dioxide and water forming this carbonic acid, which then breaks down into hydrogen ions and bicarbonate ions. And that bicarbonate is going to be pushed out into the plasma. So all of this reaction is happening inside the red blood cell. The hydrogen ion binds to the hemoglobin. We kick out the bicarbonate. And you can see as a bicarbonate comes out, a chloride has to go in. So you're going to see the chloride movement here as we switch a bicarbonate for a chloride. And this bicarbonate is going to float in your plasma. So do we still have 7% CO2 dissolved in the plasma? Yes. Is some of the CO2 going to stay directly bound to the hemoglobin? Yes. 70% is going to go through this process of creating carbonic acid and then breaking down into bicarbonate, and that bicarbonate is going to travel in the plasma. You may or may not remember the bicarbonate buffer system. The whole reason we're breaking down CO2 into bicarbonate is that it can buffer pH changes in your blood. So this is at the systemic. We're picking up the oxygen, we're transforming it into this bicarbonate. The bicarbonate is flowing in our plasma, and when the bicarbonate reaches the lungs, you're going to see the bicarbonate move back in, you're going to see chloride move out, you're going to see the hydrogen bind with the bicarbonate to form this carbonic acid, turn back into CO2 and water, and then you're going to exhale the CO2. Just to kind of recap, hemoglobin can transport oxygen, carbon dioxide, or hydrogen ions. So if it's the oxygen, it's attached directly to that iron group. If it's carbon dioxide or hydrogen ions, they're actually attached to the protein. And they want you to see that the attachment of one can affect the attachment of others. So here we're talking about hemoglobin and binding of oxygen. So we know that the oxygen molecules are bound to that iron atom at the hemoglobin center, right, that heme group. The percentage of oxygen saturation of hemoglobin is critical. So this is what we were just looking at. We said it should be over 95%, right? So the amount of oxygen bound to the available hemoglobin. Saturation increases as oxygen increases. We call this a cooperative binding effect. So they're saying each oxygen that binds causes a change in the hemoglobin that makes it easier for the next oxygen to bind. And how many can we hold total? 4, right? So we're going to see on the next slide, we're going to look at the curve or the graphed oxygen to hemoglobin saturation. So this image here is showing you the amount of oxygen, right? Partial oxygen. And here it's showing you the percent of saturation. So basically, as oxygen levels increase, more oxygen binds hemoglobin. And then they're showing you at the pulmonary versus the tissue. So they're saying as the amount of oxygen available increases, the more oxygen is bound. This is really great at the pulmonary, right? If you're trying to breathe in oxygen, the more oxygen you have, the more hemoglobin and oxygen bound you have. We're getting as much oxygen bound to hemoglobin as we can in our lungs. This does change with altitude. So I said we're going to kind of stick here at sea level, but you could see that the amount of oxygen available drops, and if the amount of oxygen available drops, then the amount of saturation drops. So right here at 65, we're going to be right about here. We've dropped from 98 to 90. It's still not that much. So you'd have to have an extreme altitude change. You know, maybe going up to Mount Everest, which is, what, 29,000 feet, somewhere around there, to see a huge drop-off. So for most of us, we're okay. We're still in the 90% of oxygen saturating our hemoglobin. What happens when you get to tissue? If you're at rest, they're showing that your amount of oxygen is at about 40. So if we're here at about 40, we're still up here at the 80%. What happens during exercise? So you're down here, we've dropped off more oxygen. So all they're really trying to show you is that the more oxygen is available, the more oxygen is going to bind your hemoglobin. When your blood gets to your tissue, if there's less oxygen available, it's going to drop off more oxygen. That's basically the difference here. So just putting into words here, they're saying if your altitude changes, so the amount of oxygen, so remember this partial oxygen, this is amount of oxygen available. If your partial pressure changes, the saturation of hemoglobin and oxygen will change. But this still really isn't that great of a decline, right? Altitude sickness can occur though because you have low oxygen saturation. It can cause headaches and nausea. It can also cause swelling, right? Edema in both cerebral and pulmonary. The takeaway point for this slide is that not all of your oxygen gets dropped off. When we're at rest, our oxygen saturation is still at about 75%, even after passing through systemic cells and tissue. So at rest, we only drop off about 20 to 25%. So that 75% is called an oxygen reserve. And why would we not drop it all off? Well, what happens if we need to do fight or flight? What happens if we need to increase our energy demand, right? If we're exercising, well, then we still have enough oxygen bound to that we can have that quick burst of oxygen release, generate ATP, and create enough energy for our demand. So a couple of background things before we look at this slide. Remember, we just talked about oxygen bound to hemoglobin. Now we're going to talk about carbon dioxide and hydrogen bound to hemoglobin. But remember that the oxygen is bound to that iron. And then we said the carbon dioxide and the hydrogen ions bind to the actual globin molecule, not to the oxygen. So they can be bound different parts of this overall molecule, right? We've got the globin proteins and we've got this iron core, and the iron is where the oxygen is. But the binding site for the carbon dioxide and the hydrogen ions are other places. They're on the actual protein. So what they're saying is if carbon dioxide binds the protein, the hemoglobin, it can cause the release of more oxygen. It's almost like a trigger. Like if CO2 jumps on, the oxygen jumps off. Same thing with the hydrogen here. If the hydrogen ions bind the hemoglobin, it causes oxygen to be released. So this affinity is decreased and it causes oxygen to be dropped off. So in both cases, if CO2 and hydrogen attach to the globin, it causes the oxygen to be released from the iron group. This should make sense because where are these highest? If you have tissue that just did cellular respiration, it's producing CO2 that combines with water, forms the carbonic acid, breaks down into bicarbonate and hydrogen. The bicarbonate goes to the plasma, and this hydrogen goes back and binds to the hemoglobin. So if you have high carbon dioxide and high hydrogen ions, if those are binding to the hemoglobin, we're at the tissue level and we're saying drop off more oxygen. So in addition to, I'm going to draw this back up here, we've got our iron group, that's where our oxygen is bound, and then we've got the globin, that's supposed to be an I, globin proteins where we could have CO2 binding or we could have hydrogen ions binding, right? So in addition to carbon dioxide and hydrogen binding to the hemoglobin, there are other factors that can cause oxygen to be released. So if your temperature increases, this hold on oxygen diminishes. So this hold here and more oxygen increases oxygen drop off. This BPG molecule, this is a byproduct of cellular respiration. So this molecule can bind the hemoglobin and cause more oxygen to be released. So again, we can have another molecule bind, this 2,3-BPG, and that could cause the oxygen to be dropped off. We'll have more oxygen dropped off. And that should make sense if we're talking about we just did a whole bunch of cellular respiration, that facilitates more oxygen drop off. We're at the tissues. Also temperature. Does your temperature elevate when your muscles are working really hard, right? Some of that energy that's transformed gets released as heat. Also, certain hormones can stimulate the blood cell to produce that byproduct. So thyroid has something to do with metabolism, right? Epinephrine, adrenaline, growth hormone, testosterone. These can also trigger this 2,3-BPG, which would then cause an increase in oxygen drop-off. So they're showing you here again, pulmonary gas exchange, and we're seeing that after the tissue pushes the carbon dioxide into the blood's going to travel to the lungs. We're going to reverse the reaction so that we can exhale the CO2. So sometimes you'll see me write CO2 plus water turns into carbonic acid, which breaks down into bicarbonate and hydrogen ions. We're driving the reaction this way at the tissue. That's where the carbon dioxide is being pushed into the blood. So I'm at the tissue and I'm doing this, and this bicarbonate is traveling in the blood. This travels in the blood. When I get back to the lungs, I want to drive this reaction the other way. I want to take the bicarbonate, combine it with the hydrogen ion, turn it into carbonic acid, turn it back into water and CO2 because I have to exhale that CO2. So we just looked at some variables that can decrease this affinity and cause oxygen to be dropped off. We said increased temperature, increased hydrogen ions, increased CO2, increased BPG. Why would releasing oxygen be good? Because if we have high levels of all of these items, we're probably at the tissue level, right? We probably need to drop off more oxygen so we can make more ATP. There are variables that can increase oxygen affinity. So making this bond stronger. So if you increase the hemoglobin oxygen affinity, you have no or less oxygen drop off. So if you have decreased temperature, if you have decreased hydrogen ions, this affinity is going to be greater and you have less oxygen dropped off. This image, we're looking at how temperature and how pH influence hemoglobin saturation. So remember, hemoglobin saturation is hemoglobin and oxygen bound. So in this line, the first line, they're showing you that it's colder than normal. So this is the normal. Do you see how it's more of a straight line? They're saying the hemoglobin stays bound to the oxygen longer, even if the levels of oxygen decline. So if you're cold, you don't release oxygen as much. What happens if you're warm here in red? Do you see how it drops pretty fast? So we're here versus here at normal versus here at cold. So all they're saying is if your temperature is hotter, you're going to drop off more oxygen. If you're colder, the oxygen is going to stay bound to the hemoglobin longer. pH, again, that has something to do with hydrogen ions. So they're showing you if you're alkaline, it's the same effect as being cold. You're going to see the oxygen bound to the hemoglobin for longer, even if the levels of oxygen are dropping. And that if your pH becomes more acidic, you're going to see the oxygen fall off more quickly. So we have to go over some of these terms. Hyperventilation. This is exhaling too much CO2. So you're blowing off or exhaling too much CO2. You're losing CO2 from your blood. Hypocapnia, hyperventilation. If you have low blood carbon dioxide, it's going to cause vasoconstriction, and that decreases the amount of oxygen that can be delivered to the brain. You're in what's called respiratory alkalosis. So something happening in your lungs is causing your blood to be alkaline. Hyperventilation, you can feel dizzy, there's numbness, tingling because your brain's not getting enough oxygen, right? You can lose consciousness. Your body says, well, if I have to fight gravity and I'm not getting enough oxygen, I'm going to pass out, and then maybe I'll have an easier chance of getting oxygen to my brain. Could put you into a coma and even possible death. Hypoventilation, you're not exhaling enough CO2. It's shallow breathing. You're not exchanging air enough, right? So oxygen levels are down, CO2 levels are up. We know CO2 makes your blood acidic. Your tissue is going to be hypoxic. Blood CO2 levels are going to increase. So hypoventilation, too much CO2 in your blood. We know that this is acidic, so we call this respiratory acidosis. Something going on with your lungs is making your blood acidic. And having too much CO2, this can cause sleepiness, headache, increased red blood cell production. This is you're not delivering enough oxygen to your tissues, so inadequate oxygen delivery. It can cause loss of consciousness and death. So now we're talking about exercising. So while exercising, we need to increase the tissue's needs. We need to increase our breathing to meet those needs. So this is hyperpnea. So we are going to increase our depth while the rate remains the same. So the amount of oxygen and carbon dioxide remain relatively constant because we are compensating in other ways. We're breathing deeper, more air in. We're increasing our cardiac output, and we kind of equated that to blood pressure, right? And we have greater blood flow because of that increased blood pressure. So more blood is getting to the tissue. And if you remember that image from Cardiovascular, I think it was like 10 times as much blood flows to the skeletal muscles during exercise. We're also going to stimulate that respiratory center. The proprioceptors, remember these are all coming from the muscles and the joints. So if they're being used more, they're going to send signals to the brainstem. That's going to cause that increased depth. Also the motor output from the cerebral cortex. Remember the cerebral cortex is sending the message out, the coordinated motor muscle action. Remember motor output comes from the frontal lobe. This can also trigger the respiratory center as those motor output messages are relayed down through the hypothalamus, through the brainstem. They can trigger the respiratory center to cause that increased depth in breathing. Well, this is it for the respiratory chapter. Next, we move into urinary. I'll talk to you soon. Bye.